Bom dia. So I have the task, first of all, I need to tell you I'm a surgeon. I've spoken to you about active surveillance, that's not surgery, surgical topic, and molecular biology topic. As a surgeon, I recognize biology of cancer is king. I could always tap my back on the shoulder and say, you did a good job, you cured that patient. By and large, most patients are cured because their biology is indolent. So a large part, half of my professional career is invested in understanding the biology of endocrine cancers and hopefully developing some effective therapies, as well as optimizing the selection of what patients need aggressive treatment. So I'm going to talk about the molecular pathways, or I've been asked to talk about the molecular pathways associated with mortality and papillary thyroid cancer. I have a patient that I took care of that had anaplastic thyroid cancer that progressed from a poorly differentiated thyroid cancer. Needless to say, even after a toilet thyroidectomy and lymph node dissection, this patient didn't survive. So clearly, we need to do a better job of understanding which patients die of their disease. Perhaps clinically, what one deals with, by and large, in the developed world is recurrent and persistent disease. I really believe that's a figment or a creation of the advanced medical care, and that's probably not going to result in the adverse outcome of these patients. So our focus, at least in cancer and cancer treatment, should be to reduce mortality and not to act on subclinical persistent recurrent disease. So what is the point of this and understanding the molecular pathways that are involved? Well, we could select which patients actually need aggressive surgical treatment up front, need total thyroidectomy, lymph node central prophylactic neck node dissection, which patients need radioiodine ablation, which patients long-term need thyroid hormone for TSH suppression. And what I have there is really a theoretical product, because I think this is what we're dealing with here. You heard a nice talk, 2 talks about risk stratification, low risk, intermediate, and high, and now we're talking about we need to reclassify patients after we've treated them. And that's really the limitation of our understanding. This is the overlap of the patient. So if we come up with markers or identify molecular pathways that clearly separate those patients that are low risk way before we treat them, and clearly identify which patients are high risk before we treat them, so we could give them aggressive upfront therapy, that optimizes patient outcome. So it's important to study this and understand this. The other reason to understand the molecular biology of aggressive papillary thyroid cancer is you could develop targets for therapy, and for BRAF now we have targeted therapy that's being used in melanoma with reasonable response rates. It also allows us to really, as I said, provide precise treatment of patients, and as a surgeon I'm always interested in markers that helps me decide which patients I should embark upon aggressive treatment. So, at least in the US, and I think in many nations, there's usually a rigorous evaluation of markers of prognosis or markers of diagnosis. And there have been many in the literature that have been proposed for thyroid cancer in general and papillary thyroid cancer specifically. What's very interesting, though, is the only tried and true cost-effective marker that we still use, don't get me wrong, it's been a major advance in thyroid cancer, is thyroglobulin. But we're at the point in the care of these patients that I personally believe thyroglobulin is too sensitive. That in the patients that have the aggressive cancers that are poorly differentiated, it's not a great marker. And the patients that have low, intermediate risk, it's perhaps too sensitive and makes not only the providers, but the patients aware. You know, we use the cancer diagnosis lightly, but when you see the patient for follow-up, yes, I'm a surgeon. Okay, well, your thyroglobulin is detectable. It's 3 nanograms per milliliter. For the patient, that means they've got persistent disease. And many of the endocrinologists will investigate the patient because of that. So I don't want to minimize how important it is in following patients, but I think there's a lot of anxiety provoked from the patient. There's a lot of healthcare expenditure societally based on a detectable or an elevated thyroglobulin. So clearly we need better ways of predicting who's going to do well or not. This is a model much like for colon cancer that has been proposed and validated. It's a gene-centric model for the development of thyroid cancer. As many of you know, BRAF mutations are very common, RET-PTC rearrangements. We think this is an early event in the carcinogenesis of papillary thyroid cancers because from the Korean studies, up to 80–90% of occult papillary thyroid cancers are positive for BRAF. Most people believe that you need a second or a third hit, specifically a p53 mutation, to progress to anaplastic thyroid cancer. And then the two different type of histologic thyroid cancers, follicular thyroid cancers, RAS mutations, PAX, PPR, gamma are much more common. Unfortunately, people have tried to use this for diagnostic markers, and you could see you find them in follicular adenomas. And then lastly, we really don't understand the cancer initiation in Hürthle cell carcinoma, where RAS mutations have been identified, but by themselves cannot be driver mutations. This is the Cancer Genome Atlas. I think it was a very important study that was carried out in 496 papillary thyroid cancer. There are some shortcomings to it when you look at cancer progression, as the rate of mortality in this cohort of 496 papillary thyroid cancer was quite low. Very few of the tumors were high-risk tumors. And certainly a mortality rate of 5% in this cohort is fairly low, but I think this will be instructive and informative with the studies I'll share with you when you look at predictors of progressive disease, because those are precisely the patients you want to identify. And the follow-up time in this cohort is extremely small, a median follow-up time of 2 years. So for those of you that have not seen a heat map, I will go through this because I think it's really informative. It's really an interrogated genetic genomic analysis of papillary thyroid cancer. Well, no surprise. Over half of the papillary thyroid cancers have a BRAF mutation, as well as a RET-PTC rearrangement and RAS mutation. But what this told us is only 4%, and I think you heard this in the talk earlier yesterday, that we do not identify driver mutations in these tumors. So one could classify, based on the downstream targets of the BRAF mutation or RAS mutation, as a papillary thyroid cancer being BRAF-like, based on the gene expression profile, or being RAS-like, based on, again, the target downstream tyrosine kinase proteins. So why is this important? Well, most of the differentiated thyroid cancers that kill our patients go on and progress, become dedifferentiated, poorly differentiated tumors, and about 1% or less will become anaplastic thyroid cancer. And this is a really nice study by Jim Fagan's group, because they compared the data from the TCGA, the Cancer Genome Atlas study in papillary thyroid cancer, and they looked at all of the driver mutations in patients with poorly differentiated thyroid cancer, anaplastic thyroid cancer. And as you can see, there's a common theme, an overlap in BRAF mutations as well as RAS mutations, meaning these are likely, that is, well-differentiated thyroid cancer is the origin of poorly differentiated thyroid cancer and anaplastic thyroid cancer. We've always talked about this. This is nothing new, but it is actually molecular evidence that suggests and supports this hypothesis. So how could we better predict those papillary thyroid cancers that are going to progress to poorly differentiated or undifferentiated thyroid cancer. And perhaps the way we could do that is looking at the TERT promoter mutation. So what they found is, although this was identified in papillary thyroid cancer and poorly differentiated thyroid cancer and anaplastic, the rates were much higher. Up to 2/3 of these tumors had a mutation in 2 hotspots of the TERT promoter. And as you could see, there was some overlap with patients having coexistent BRAF mutations as well as RAS mutation. So perhaps if you do a fine needle aspiration biopsy of a thyroid nodule, it's BRAF positive and it's TERT promoter mutation, that's the patient that's going to have aggressive progressive disease. Well, sure enough, there's been clinical study that specifically looks at it. So from a molecular biology standpoint, if you're a gene-centric person where you believe driver mutations are the main cause of cancer progression, classic papillary thyroid cancers are characterized by mutations in BRAF as well as RAS mutations, including the classic or conventional variant of papillary thyroid cancer and the follicular variant, which has a very high rate of RAS mutation. So if you have a patient that has a papillary thyroid cancer on cytology that is positive for a RAS mutation, as a surgeon, maybe that's the patient I would consider doing a hemithyroidectomy in if it's only 1.5 centimeters, because it's very likely for it to be a follicular variant of papillary thyroid cancer. I'm just sharing with you clinically where you could apply this information, but we're far from it as far as having robust clinical data. And those patients that end up having follicular thyroid cancer, poorly differentiated or anaplastic thyroid cancer, they most likely have mutations that activate the PI3 kinase AKT pathway, and that's perhaps how you could identify those patients with follicular thyroid cancer that's well differentiated that might progress to anaplastic or poorly differentiated. So at this point, I'm going to share with you some of the work we've done and many other colleagues have done where I think is very close to the clinic. And certainly at my institution at the NCI now, we liberally always test for BRAF mutations, and some of the mutations I share with you. We had instituted it principally because of earlier studies I had done in San Francisco, and I know my colleagues there are doing it, as well as colleagues at Memorial Sloan Kettering and colleagues at MD Anderson. So many of the leading institutions in the US are prospectively collecting this information with the idea of, can we actually determine response to treatment? Nobody yet is using it to decide on the extent of thyroidectomy or lymph node dissection or the use of radioiodine. So one could put this in 4 different umbrellas. There have been multiple genome-wide expression studies. I'll share with you the studies we've done and that have been independently validated by colleagues in Korea. Micro-RNA profiling studies to predict which tumors are poorly differentiated or undifferentiated, and some of the sequencing data. So one of the first studies looking at BRAF and outcome of patients was by Ming Xiaozing at Johns Hopkins. They looked at a cohort of over 200 patients, and they found patients with BRAF positive thyroid cancer, this included patients with poorly differentiated thyroid cancer, did much worse, this is disease-free survival, as compared to those patients that were BRAF negative. The study was initially criticized for not doing a multivariate analysis, including histologies that you know are going to do bad and have high prevalence of BRAF mutations. And certainly the treatment approach in these patients was not uniform, so could have determined their outcome. Well, we were very intrigued by this finding, so we did this in a fairly homogeneous group of patients that all had total thyroidectomy, that all had radioiodine ablation, and that all had thyroid hormone for TSH suppression, and we did do central neck node dissections that is therapeutic in patients with clinical N1 disease. What did we find? Those patients that have BRAF mutations were older and had a higher rate of lymph node metastasis as well as distant metastasis, and of course higher stage cancers and a higher Ames risk group. What was really intriguing in the application of this perhaps clinically was if you look at those patients that had stage 1 disease, this is a primary tumor less than 2 centimeter with no lymph node involvement, and patients that were low-risk Ames group, those that had a BRAF mutation were 2 times more likely to have both a central neck recurrence or a lateral neck recurrence. Well, several centers have reported a positive association with BRAF positive papillary thyroid cancer and worse outcome, and some institutions, principally from Italy and some groups in Korea, have found no association. Mingxiao Zheng, to his credit, included all of those institutions' data and a very robust sample size of over 1,500 patients and looked at whether BRAF positivity predicted patient disease-free survival as well as overall survival. And as you could see, those patients that had BRAF positive tumors did much worse. In fact, when you look at those patients that had BRAF negative tumor, their life expectancy was near normal for almost 12 years. And similarly, when you look at specifically those patients with classic papillary thyroid cancer, which have an extremely good prognosis, those that had positive BRAF mutant cancer had a lower overall survival. What is wrong with this, though, in a practical standpoint? I'm always excited about science that has translational applicability, is when you look at all of the different countries that participated, nearly half of the papillary thyroid cancers were positive. So you would end up over-treating a good significant number of patients. So this mutation is too prevalent to be applied clinically, I think personally. Well, I shared with you how more aggressive tumors have TERT promoter mutations, those that are poorly differentiated or anaplastic thyroid cancer. And I really think, again, this is a study done by Mingxiao where they, in addition, evaluated TERT promoter mutation. And as you could see here, in combination, the BRAF and a TERT promoter mutation, those patients had a much higher risk of recurrence, 70%, as compared to a little under 20% if one or the other mutation was present. And this is really significant. So when you look at the recurrence-free survival, those patients with both a BRAF and a TERT promoter mutation do dramatically worse. So this is something you could clinically know upfront based on the FNA biopsy and getting it tested for a BRAF mutation and a TERT promoter mutation. And then he specifically looked at those patients with classic or conventional papillary thyroid cancer. And this outcome is unusual. We say prognosis is very good. So to me, this really defines the subgroup of patients, mind you, with classic papillary thyroid cancer that are going to have aggressive cancers and that are going to die from it or are going to have clinically significant recurrent disease. So that is for the mutation analysis, and I think that's where we are. How about the work on microRNA profiling? There have been numerous studies done in Europe and US and South America that have characterized the dysregulated expression of microRNAs. For you clinicians not familiar with microRNAs, they're important because they target genes and regulate their expression. So a microRNA that is underexpressed, a gene target would be overexpressed and perhaps drive the cancer biology. This is a heat map where the blue indicates the genes or microRNAs that are downregulated, and the red indicates the microRNAs that are upregulated. What you notice here is the MIR30 cluster of microRNAs are downregulated in anaplastic thyroid cancer and not downregulated in papillary and normal thyroid tissue. So Dr. Bofrikich then went on to independently validate it in a cohort of patients that we operated on. And as you could see, those patients that had poorly differentiated thyroid cancer or anaplastic thyroid cancer had a markedly lower level of the microRNA A. So we were interested in looking at this if it's a predictor of survival in just patients with conventional papillary thyroid cancer, and she went and looked at the Cancer Genome Atlas data, and those patients that, according to the MACES risk scoring system, that had high-risk tumors overall had lower microRNA expression, but there's a significant overlap in those patients with low-risk disease. And similarly, when she asked whether if they're alive or dead, the patients that were dead had lower microRNA level of expression in their tumor. She went on to discover the target for this microRNA, which is called LOX, lysyl oxidase, and it's an important protein that's involved in cancer progression. And what she did was demonstrate that microRNA directly binds to LOX. When she overexpressed it, LOX expression disappeared. But what is more biologically, perhaps more clinically relevant, is in a mouse metastatic model, these mice develop lung metastasis. If she reduced the microRNA 30A level, they develop florid metastasis. When she increased them, the LOX level reduced and the mice developed less metastasis. So because of that, we looked at LOX protein level, again in the Cancer Genome Atlas, and as you could see, the patients that died of their disease had much higher LOX level. This is just papillary classic thyroid cancer. And I think what was striking and clinically, I think, potentially useful is when you look at the patient that has conventional or classic papillary thyroid cancer with a good outcome, they don't express the protein, nor do you see it in the normal tissue, but then those patients that have tall cell variant of papillary thyroid cancer have high levels of LOX. So perhaps on a post-surgical histology pathologic analysis, this is what you could stain for determining which patients have aggressive disease. And there have been many studies like this, so I think it's important for other investigators to also find the same thing. And this is a group, and independently also found that LOX levels were high in patients that have BRAF mutations. So here in pink are the upregulated LOX expression. And what they did, unlike what we were able to do, is actually look at disease-free survival based on patients that had high LOX expression level compared to those that had low. And as you could see, the disease survival or disease-free survival is significantly lower in those patients that had high LOX level. Again, perhaps adjusting a translational aspect of it. Genome-wide expression studies that have been done, we were one of the first groups to do this, and compared patients who died, and mind you, this is conventional papillary thyroid cancer, that died of their cancer compared to those patients that didn't die with a median follow-up time of 9.5 years. And we identified 6 genes, 2 of which were upregulated, 4 of which were downregulated. And then after this exploratory analysis, we went on to validate this in an independent cohort of patients, 60 initial validation cohort and an independent cohort of 26 patients. And this gene is CPSF2. It was lower in patients that died of their disease. And what's intriguing is you could stain for this protein, and as you could see, a tumor of a patient who died of their disease is positive for this, while a patient rather is positive for it, that is, if they're not dead of their disease, and those patients that died of their cancer have loss of expression of this particular protein. So is this really clinically useful? Well, it's great. Our Korean colleagues actually validated the same finding in patients with just conventional papillary thyroid cancer. What did they find? Patients that didn't have expression of this protein were much higher rate of recurrence as compared to those patients that had expression of these proteins in this tumor. And they also found that this was actually independent of BRAF mutation status. So perhaps this is something you could use in the clinic to study. When they look at the disease-free survival, those patients that had the CPSF2 negative expression did much worse, again, than those that were positive. So this is really a translational or a clinical application of this. Lastly, I'm going to go through tumor immunomodulators because there have been targets that have been developed for these. Dr. Laura did a great job yesterday to go and giving us an overview of thyroid cancer immunomodulators. PD, PD-L1 are important checkpoints of a T cell reaction to cancer cells, and typically either the tumor cells itself or the host environment will express the PD-L1 and inhibit the action of a T cell that is targeting the tumor cells via the PD-1 protein and the receptor. So people have actually looked at PD-L1 expression. It's very low in normal tissue and it's high in cancer. It's thought to be expressed not only by the cancer cells but also tumor macrophages. And what you look at is when you look at different cancer types, high PD-L1 expression in different cancer types is associated with a worse survival. And this has been looked at in differentiated thyroid cancer actually by Dr. Ward's group right here in Brazil. Really elegant study characterizing the expression of this protein. It's been associated with older age. It's an important prognostic factor in patients with differentiated thyroid cancer, a higher cancer stage. And in their study, Kuna and colleagues clearly demonstrate it's associated with T cell infiltration of papillary thyroid cancer. So what we did was then ask, could this be also a prognostic marker for, again, garden variety conventional papillary thyroid cancer? It was interesting is we did see an association with lymphocytic infiltrate. In the talk, just 2 talks earlier, we saw a very nice overview about the hypothesis, is chronic lymphocytic thyroiditis lead to thyroid cancer, or is it a founder effect where we're taking care of patients with thyroiditis, or is it an immune response to the thyroid cancer itself? This would suggest perhaps it is an immune response to the thyroid cancer itself. Very few tumors stained positive for the PD-L1 protein. And when you look at the PD-L1 positive tumors versus negative, this is unpublished data, you see those that have high levels of PD-L1, again looking at disease-free survival, have a much worse disease-free survival as opposed that have low PD-L1. We did not quite see a statistically significant difference in overall survival. So I'm going to finish up by summarizing. I think I'm running out of time. I think there are key points. I think we've learned a great deal about the molecular biology of papillary thyroid cancer and thyroid cancer in general. I think certain genetic analyses are ready for prime time clinical use, and many centers are already testing for BRAF mutation, TERT promoter mutation. We're not quite there where we're deciding the surgical treatment or adjuvant radioiodine ablation or TSH suppression, but I think it's incumbent upon us, at least I'm biased, when we get a patient that has an FNA biopsy that's BRAF positive, TERT promoter mutation, I'm more likely to do a central prophylactic dissection in that patient. So hopefully we'll have that outcome data in another 5 to 7 years, not only from our center, but other centers that are using this information. Much of the microRNA profiling studies, I think we had a fantastic talk yesterday where that was being applied to determining whether a thyroid nodule was benign or malignant, and there's some commercial assays. I have some reservation as far as reproducibility, so I don't know if this data is going to be as good for prognostication. And I think at least post-surgical immunohistochemical analysis for PD-L1 and CPSF2, which are being already done for colon cancer and melanoma, is something that many people could implement in their institution to perhaps guide their treatment. Again, we don't have outcome data, but until we start implementing and using this information, we won't have that clinical data. So I'll finish up by saying obrigado, thank you for your attention, and thank you for a kind invitation. This has been a fantastic meeting to attend. I've learned a great deal that we have the same problems, but some of the problems are not the same, and I've also learned we have very different approaches, and some of the approaches that I'll consider taking back home and implementing. Again, thank you for the kind hospitality, and I want to congratulate the program committee for a really very informative 2-day meeting on thyroid cancer.